Mouse. Exactly, thank you. Thanks, Dion. So this is quite a quick session. Mandatory training of CPR in schools is probably not a low-hanging fruit per se, but we do know that the countries that have successfully achieved this over time see an improvement in out-of-hospital cardiac survival rates. So again, this is a bit of a slow fuse. The more children, obviously, that understand and are familiar with CPR and AED use, the better for our communities. So we do have a few challenges, of course. Our goal is to train 100% of high school students in time. So compulsory training does happen elsewhere. It commenced in Norway back in the 1960s, and they're certainly reaping the benefits of that now. We've seen other countries pick it up, certainly Canada, parts of Great Britain, certainly Scotland recently, United States, Scandinavia, and some other European cities. Where it's not compulsory, we see a lot lower community uptake of CPR and first aid training. So it's getting it instilled into children early on and it becoming a bit of a norm, really. And how do we do that going forward? And even in some cases where it is legislated, there are still gaps in implementation because there's many factors that impact on the provision of CPR training in schools. So I just want to preface this with saying that we should recognise that even without it being mandatory, across Australia and New Zealand, many, many thousands of school children are being trained in first aid and CPR in schools, and hopefully AED use. And that's a byproduct of organisations like St John Ambulance and local ambulance services who have seen the value in doing this prior to the 10 steps coming in, as it's just a good community activity. The challenge we have in both Australia and New Zealand, and the situation is very similar, is that in the curriculum there is room for CPR training, part of the physical education program. But it becomes very dependent on the individual teachers leading those programs as to where and when it's done and the quality of the provision. So one of the things that we need to do is work with local politicians, both in health and education, and federally, to I guess, have the conversation once again about how can we make this mandatory, particularly for Year 9 and Year 10 students, and preferably for Year 7 and 8 students. And there's no reason why we can't take it lower. But at the end of the day, it becomes a cost issue for schools, both in relation to having staff deliver the program, finding time in the curriculum, having a program that's condensed enough to fit into a teaching spell, and of course, having the quality of educator to provide that particular program. So the situation in New Zealand is exactly the same. The curriculum is set by government and it's included as an option, and it's up to individual teachers to initiate that from happening. So, ways of addressing this. It's been an interesting journey so far. We've started the conversation. At the end of the day, it usually comes down to funding and experience. We have had the government of Australia and New Zealand lobbied on many occasions previously to make CPR training mandatory in schools, but typically that lobbying has come from the providers of first aid training. So it's always perceived as a conflict of interest. So they don't get a lot of airtime, even though the principle of what they're saying is good. So we need to change that. Certainly, the free training we see we don't want to end. That's great. But we need to do this advocacy piece. Currently, there is a e-petition, electronic petition, in Australia, calling for mandatory CPR and defibrillation training for school students. I looked at that yesterday. It only has about 79 people signed up. Maybe this is an opportunity for us to get a whole lot of people to jump on board and sign this petition. At least it might get a bit of airtime. Equally, there's a big project in New Zealand at the moment where the New Zealand Heart Foundation is looking to put together a framework and potentially lobbying government around first aid training in schools. It's not perfectly aligned to what we want, but it's certainly a vehicle we can hitch our wagon to. So barriers, obviously not being mandated is key, and where it is mandated, in some areas it's suboptimal. I think we have a massive role in sharing our 10-step story with schools. Certainly Restart a Heart Day activities provides a great platform for that. And if we could get schools to start participating in Restart a Heart Day, it will partly address that issue and give perhaps some of the teachers and other staff more confidence, to initiate the program and even deliver the program. So that is certainly a focus for us for Restart a Heart Day, both this year and going forward. So what's the role of, we've got some other organisations in Australia and New Zealand who are in the position to advise government that this is a good idea. So we certainly got COAG, and COAG has a health arm and an education arm. So we could lobby COAG and get them to start promoting it through their channels. The ACARA, which is a curriculum group, we need to spend more time lobbying them and improving the value of CPR training in schools. So that's a piece of work that the CAA, with approval from the CAA board, is going to do post-conference. We'll just get this out of the way, and then we can start doing that. But it's really important that we start the conversation. So, I mean, the ultimate goal, obviously, is to get this embedded. We want to see CPR in the curriculum as early as possible, but certainly in those latter college years where we will have, deeper understanding and deeper capability. And we may have to work with other agencies to identify new sources of revenue to assist that in happening. And we have a whole group of people who are mission aligned on this, so it's about bringing together the collective voice. And we are currently starting work with, or working currently with, the Primary Principals Association in both countries, the Department of Education, St. John Ambulance National, Heart Foundation. The list is there. I won't read it all out. But these people are all obviously supporters of CPR training in schools. And some of them are providers, some of them are not. But they have great advocacy capabilities, so we need to harness that. Role of the CAA, we need to lead some of this as it is a national initiative, but we also need to work with ambulance services because it's also a local initiative. So it's definitely a two-pronged approach. We hope that we're going to succeed in this instance because we're apolitical, and certainly we're a charitable organisation working on behalf of ambulance services and not benefiting financially from the provision of this training. And I think just watch this space. We will work really hard on this project over the next year, and hopefully next year when we get to report back, it'll be great to report some progress. Well, thank you.
Thanks, David. A very important subject. As I think, as we all know, we've seen examples where these kids that we train in schools go back into their communities and then train their parents and show them what they've learned. So it sort of has added benefits from just training the kids and the future generation. So we're now going to move on to step 10, working towards a culture of excellence. And first up will be Karen Smith from Ambulance Victoria, talking to us about the out-of-hospital cardiac research overview. Thanks, Karen.
You're messing with me by doing it out of order. I was like, okay. And I'll keep this one brief as well, because I don't know about you guys, but I really need a drink. And, maybe if we finish before 5, that'd be great. And I have to declare my conflict and say that as a Director of Research for Ambulance Victoria, I'm in no way biased by saying that research is the fundamental key to improving outcomes and delivering a high quality service. So completely objective presentation. So all know the 10 steps. We've shown them a number of times today, and I really think that research is essential to improve on every one of those steps. So the mantra, measure, improve, and use the registry to look at gaps, implement initiatives, and then see whether those initiatives have delivered to the expectation that they were let out to be. So just to give you a bit of an overview of the importance of research, and there's a lot of evidence base out there that shows that health services that have active research programs actually deliver better patient outcomes, even for the patients that aren't involved in the trials or the particular study. So it does generate increased scrutiny and a culture of performance improvement and culture of excellence that all patients benefit from. So it fosters a learning environment. It provides an evidence base for pre-hospital practices, and we all know that a lot of the things that we do don't have a clear evidence base or have been extrapolated from emergency departments, and they might not have the same applicability in the pre-hospital space. So it really is on us to prove that what we're doing is appropriate and the best care. It really does result in increased scrutiny, and I think this is one of the reasons why patient outcomes improve in healthcare services that are actively participating in research. Is you really start looking at what you're doing. It provides an opportunity to identify health inequalities and areas for improvement. It really does contribute to standardisation of practice. So particularly with clinical trials, you really look at the clinical practice guideline that the trial is relevant to, and it results in a lot of standardisation and reduced variation, which is really important in the healthcare setting. It ultimately improves patient outcomes, and we really find that it improves staff health and satisfaction. And we're really pleased to be rolling out a trial at the moment, which is a feasibility study, nothing to do with cardiac arrest, it's around sepsis, but we're excited about it because it's our ALS paramedics, not so much our MICA paramedics, who tend to have been the focus of our clinical trial kind of enrolment advocates. And it really does contribute to the professional standing and positioning of ambulance services. So the more that you can show that you're investigating and researching your patient population and you're showing an evidence base for your clinical practice guidelines, the higher your professional standing. And I really think that there's a significant advantage of the research being embedded within the emergency medical service or the ambulance service itself. Great to collaborate with universities and get unbiased because I'm embedded within an ambulance service, but I think you really know the problems of the ambulance service that you're working for, and so therefore your research is much more likely to be strategically aligned with the strategic plan, and in fact you can write a research strategy that's aligned with the strategic plan. And you're known to paramedics, so there's the level of trust there which facilitates patient enrolment and paramedic engagement. You can supervise paramedics who are doing postgraduate studies and have them sort of embedded within the ambulance service and enrolled through universities. And I really do feel like the results that you produce from research that's coming out of the ambulance service, and the Resuscitation Academy in Seattle say this: if you've seen one EMS, you've seen one EMS. You're much more likely to have your results translated into practice change. So you're not doing research for the sake of research, you're actually doing research that results in actual practice change within your organisation. We also find that we can rotate alternative duties or light duties, or we have a lot of pregnant paramedics who love coming to work in our research department. And then they go out and spread the word about, make sure you fill out your patient care record properly, and what we're actually putting into our documentation actually does impact how we can interrogate our data, and that ultimately impacts patient outcome. And also, we use our research a lot for good news stories. There was actually some media around one of our papers this morning, and I think there's a bit more happening. And we've looked at the drivers of our demand, and it's not the elderly population that everyone sort of says. So there was some radio interviews this morning on that. So again, the mantra: you can't manage what you don't measure. And research and registries make research much more cost effective. So if you're planning on an out-of-hospital cardiac arrest research strategy, you really have to have a good quality registry. I've talked about registries, so I'll skip over that. I like this. This is actually the Scottish Ambulance Service diagram when they're looking at their chain of survival, and the fact that the registry underpins everything that they do, so that they can measure everything from community readiness right down to aftercare. And aftercare, I think, is one of the areas actually where we have done very little research. And I was privileged enough to present at a conference, or be invited to present at a conference in Sweden earlier this year, all around post-cardiac arrest care. And it became really apparent that we're really not doing anything in the... There's a lot of great research and evidence-based guidelines around post-stroke care and stroke rehabilitation and other key cohorts, but very little in the cardiac arrest survivor space and what we should be doing with these patients. So I sort of came away from that meeting and contacted one of our cardiac arrest survivors, who also was previously a journalist, and we've started doing some work on developing a web page for survivors, and which is based on a UK website which is for survivors. They've got a closed Facebook group for survivors, and we're trying to get something similar like that happening in Australia. And I just wanted to give you a little overview of how we've used our registry data to actually change practice. So this is Kylie Dyson's PhD, one of her PhD studies. So she was an ALS paramedic with AV who did her PhD with us in Monash University. And I think most people have seen this study, but she looked at the exposure that paramedics have had to arrests. She looked at the number of arrests they'd seen in the 3 years before each incident case. She looked at their years of experience as a paramedic, and she looked at the number of months since they last attended arrest up to the incident case. And what she found was that the number of arrests that the paramedics had seen in the 3 years, we don't have a pointer, do we? The top one is in the 3 years preceding the arrest. So as the number of arrests that they've seen goes up, the odds of survival for the patient, and this is after adjusting for things like response time by center CPR, so it really is the paramedic exposure that's making a difference. So 50% more survival in the highly exposed paramedics versus the lower. The middle one is years of experience, and there was no significant association there. And the bottom one is the number of months since they've seen their last arrest. So you see, as the number of months increases up to, it's been 6 months since the last arrest, the odds of survival go down by 30%. Another great registry study that was done by Ziad Neme, again an ALS paramedic who did a PhD with us in Monash University. We had a number of missed VFVT cases, and the organisation decided that we would go to automatic rhythm analysis for the first rhythm. Ziad did a really good piece of work using our retrospective data to see the impact of that CPG change on patient outcome. So he extracted data from the registry over a 10-year period. The automatic rhythm analysis came in October 2012, and he looked at things like time to first shock, successful cardioversion and impact on patient outcomes. And I won't bore you with technicalities, but it was an interrupted time series analysis, so it adjusts for temporal trends and other factors that are likely to predict survival. So what Ziad managed to show was, while the proportion of patients who were shocked within 2 minutes increased significantly, there was no change in successful cardioversion, and when you adjusted for other factors, our ROSC rate decreased significantly. Our odds of surviving the event, so survival to hospital decreased, and survival to discharge, the odds of survival to discharge went down by 30%. And this is just represented graphically here. This was our percentage of patients shocked within 2 minutes. So it was going down, but when we put this in, there was a bit of a step change in terms of more patients shocked within 2 minutes. But these are our survival graphs. So the first one is survival to hospital discharge, and you can see we're actually on a track to improve survival. Then we implemented the AED analysis mode, and we had a significant drop in survival. Similar for our ROSC rates, which is the bottom graph. So I've just highlighted this because it's a great example how you can use registry data to monitor impacts of clinical practice guideline changes or interventions that you may have implemented. Without the registry, we would have no idea of the impact of that decision. So as a consequence, we obviously changed our clinical practice guideline, and it coincided with Matt coming on board and rolling out high-performance CPR, but one big change with that was going back to manual rhythm analysis. And I guess I also want to highlight whether ambulance services have a role to play in looking at what's happening even before step one, in a way, which is there was a nice paper published in Resuscitation earlier this year, which I was lucky enough to write an editorial on. And it basically showed that cardiac arrest patients have a significant contact with the health service prior to their arrest. So is there opportunities there for intervention? And we're certainly going to look back in VACAR to see how and our VACUS to see whether patients have contacted or had contact with ambulance prior to their arrest, and whether there's opportunity for prevention. So they had a very large population database in Ontario, and in the 90 days preceding the cardiac arrest, 30% sought care from an emergency department and 70% attended their primary care physician. So there's definitely opportunities there to look at sort of preventive or opportunities to intervene. And another piece of work from Ziad as part of his PhD, he took the warning signs campaign data, which was aimed at patients should call 000 if they had chest pain and signs of a heart attack. He used sort of time, he got all the dates for the campaign, and then he used data from VACAR and time series modelling to look at the impact of the campaign on actual cardiac arrest incidents, with the hypothesis that if patients were contacting 000 earlier for chest pain, we may circumvent a cardiac arrest actually happening. And he showed that within the months of the campaign activity, we saw a 6% decrease in cardiac arrest incidents and a 6.4% decrease in cardiac arrest mortality. Now on to step 2. I won't do research on every step, but so you've all seen this a number of times today, and I really believe that it is how we should be looking at the chain of survival. I think the earlier that we can intervene, the larger number of patients that get impacted upon. So one of the things that we're starting to look at in Ambulance Victoria, as Laura mentioned, is the experience exposure question with the call takers, just like we've done with our paramedics. And there has been one very small study that's come out of Helsinki, which did look at call taker exposure with cardiac arrest, looking at bystander witness VFVT. And they did show a significant association between the number of calls that the call taker had seen that were cardiac arrest and patient survival. So it's really the only study that I know of that's looked at this. And we know with our call taker service, ESTA, they have a 15% turnover rate of staff every year. So there's a lot of new, inexperienced and unexposed staff coming in. So we really need to innovate around how we can keep staff, how we can upskill staff. And at the moment, they mandate their staff have a CPR, like a formal CPR training refresher every year. And I really don't think that that's helpful for a call taker. I think there's much better ways that we can educate call takers in identifying cardiac arrest. Freddie's going to talk about artificial intelligence to assist call taker detection tomorrow, so I'll just skip over that, but they've demonstrated an increase in sensitivity in their work when they've used artificial intelligence as a decision support tool for call takers. We've got a large grant application in at the moment to try and do that in AV. But there's also some ethical issues around what if the call taker chooses to override the decision support tool? Does it increase or reduce stress for them? A number of things that we'll be looking at exploring. Laura also mentioned the survey that we've been doing. So with the 158 different ambulance services that responded, almost 50% used pre-entry questions before they launched their triage tool to try and get a rapid dispatch to cardiac arrest. To me, it's like, what does this tell us about the triage tools we're using? And we really should be talking to each other and pooling data and working out what's wrong and what's the best approach. There's been some really nice research come out of Western Australia where they've used a linguist to look at the nuances of what the callers are taking and what the call takers are saying, and how that influences cardiac arrest detection. So one of the papers looked at the different types of responses with the question, is he, she breathing? When the caller said no, that was a no. When they said yes, it was taken as a yes. When they said yes, but it sounds funny, or it sounds like they're snoring. In the vast majority of cases, the call taker didn't go on to clarify that and just had it as a yes, and so they missed a lot of cardiac arrest cases as a result. Martine also did some really nice research around how the wording is about CPR instructions. So when the CPR instructions more around willingness, like do you want to do CPR, only 43% of cases had bystander CPR done. But when it was much more definitive, like we are going to do CPR, there was a much higher rate of bystander CPR. So I think these type of things are what Seattle call low-hanging fruit. Like there's a huge opportunity there to make differences with very kind of subtle changes in practice. I won't go into the high-performance CPR because Matt has covered that beautifully. But one thing I would say is that there's very little research to support that the real-time feedback makes a difference on the machines. What it is using that data that you collect and doing the debrief. So there's been a number of trials looking at the impact of real-time performance, and I really don't think real-time feedback, and I really don't think it makes a big difference. It's how you use the data and how you do the debrief. And there was a nice review by Gavin Perkins and co. Looking at that, and they sort of say that debrief is a useful strategy to improve resuscitation performance, but we still don't know the optimal delivery, and we need to do better high quality research around this to work out the best method. I'll just do one last thing on smart technologies. So I think we really need to be using our GIS data, and ambulance has amazing GIS data compared to other health services, to really be optimising where we place AEDs and where we try and do concerted effort to get lay responders signed up. There was a really good piece of work out of Toronto. They looked at AED coverage, and they show that the mathematical modelling actually gave better placement of AEDs than just following population sizes. So there's quite a bit of work. I know Steve Ball's been doing some great GIS work in Western Australia, but I think we should all be talking to each other about what we're learning there. I might just, how am I going for time? Am I 2 minutes? Okay. We're also now with the move to dispatching lay responders. I think there is an onus on us to really see what the impact of that is and how we best communicate with them, and what sort of follow-up they require. So we did have a master's student, Phoebe, who did some qualitative work on our Good Sam First responders. It was a small semi-structured interviews with 11 responders, but there were some key themes that came out of it. One of it was the guilt of not being able to respond. One sort of example was they got the alert when they were in a plane on the tarmac, and they were like, well, I can't do anything. There were concerns about safety. They found the registration process a bit confusing, so that's good feedback and things that we can work on. And one of the key things that came out was because they hadn't had alert, they thought that their app maybe wasn't working. So I think there's some key messaging there for us where we could be communicating through the app to our responders and keeping them actively engaged. And we currently have a PhD student, Brian, who is going to be doing quite a bit of surveying with our Good Sam responders, and New Zealand will be using the same survey on their responders, so we'll get a really good mixed result. One last thing about clinical trials, I think it's essential that EMS do this, that we provide an evidence base, and like I said, it standardises our care, and it's a really great way to engage clinicians. So, fostering a culture of excellence. Research findings show that excellence can be taught, and it is a habit, and research is an essential part of this. So we really need to be working together and sharing our research experience, but also doing joint research projects and really improving the outcome of our patients. So if you haven't participated in Laura's survey, please do so. I'm happy to send the link, and thank you very much.